Good evening, everyone, and welcome to the AMAWA Town Hall this evening. For those of you who don't know me, I'm Dr. Bennie, CEO of the Association. I'd like to begin by acknowledging the Noongar people, traditional custodians of the land on which we gather today, and pay my respects to elders past and present. I extend that respect to Aboriginal and Torres Strait Islanders peoples here today. Thank you to all of you who's made it in person here today, and for those of you who can't, welcome on Zoom. We value your time and appreciate your views to this very important meeting. Tonight there are three topics on the agenda. We've got COVID, PPE, and also the enterprise bargaining agreement. But before we start, just like to do a few housekeeping rules. May I please ask that you put your mobile phone on silent? The fire exits are located to the left and right of me on the stage and also up to the top. You can find the restrooms at the foyers near the registration, and for those of you at home, you know where a bathroom is. The interaction of this meeting will occur in two particular ways. There'll be a Q&A component, and there's also a Slido component. So firstly, for the Q&A side of things, the attendees here will have the opportunity to actually put your direct questions, firstly after the COVID PPE section, and then also there'll be an opportunity after the EBA section. For those of you on Zoom, you can pop your comments in. We are monitoring, recording, and we'll put the questions to Andrew. Depending on the volume, we'll get back to you. We'll pick the best one and we'll get back to you for those that we can't answer after the meeting. So we will try to endeavour to answer all your questions, if not tonight, but afterwards. Just want to remind all attendees here at the Town Hall that we do apply Chatham House rules. You guys know what that means. Having said that, a dose of reality. We cannot at AMAWA control who else is watching on Zoom. So be cautious when you are putting your questions forward, because it may very well end up on the front page of the West. So I'll just ask you to do one thing first, which is Slido. So the second component of this interaction is Slido, and next slide, please. Okay, so for those of you who haven't done it, can I ask you to log into this portal and enter the AMAWA code. While you're doing this, so this is that there'll be a few questions that we'll be asking you to take your views and guide us in how we as an organisation move forward. So while you're loading this here and online, I'd just like to let you know that as an organisation, we would like to ramp up our efforts to increase our interactions with you, especially face-to-face while we can. So we'd like to actually do this. We know that it is not exactly the same as webinars, and these type of interaction does add a lot more than just being online. So our next informal meet and greet, where you get to talk to Andrew and us, is actually over wine and nibbles for free, is on the 27th of August. So I assume most people are okay with the Slido? Yes? Okay. So thank you, everybody. So on that note, I would just like to welcome our President, Dr. Andrew Miller, to the lectern.
Thanks, Benny. Thanks, everyone, for joining. So we've done the icebreaker to let people know who we are. Can you turn me down just a little bit? I'm fairly loud just on standard analogue without the digital. We've got quite a bit to get through in terms of the COVID situation. And first we'd like to do some temperature checking and ask you some more questions around where you feel we're at. So this is both for the people on Zoom and the people in the room. So the first poll that we're going to put up is about, it's all about workplace, okay? So this isn't so much about community. What we're talking about is professional stuff. And what we want you to do is, in relation to your workplace, rate the following. So you would put in a 0 if you don't feel that these options apply to you, or you would put in 1 if you think that things are bad or the worst situation, and 9 if you think that things are great. So the first one is overall COVID preparedness at the moment, and we'll give you some time to have a think about that. The workplace will obviously vary between whether you're in the community, whether you're interacting much with aged care, which seems to obviously be one of our big dominoes in Australia that is at risk of toppling our systems, as it seems to be doing, unfortunately, in Victoria at the moment. If you're in general practice, that might depend on what type of general practice you're in and what the ownership structure is and the facility structure is around your overall preparedness. But really it refers to how well you think we would cope with a situation similar to that in Victoria. The news out of there, of course, has been pretty much blanket coverage, and I think we're all concerned about what would happen if we were the next off the bench in terms of that kind of community spread. So we'll go through the next ones a bit quicker now that you're getting familiar with the system. And I see that, to just let you know, Lizette, when you're happy that we can move on. We're giving people a decent chance there, and they're getting used to it now. So we'll move on to the next one. Have we been able to answer all of these on our phone at the moment? Okay. So you've looked at the ability to cope with some moderate and cope system-wide with a large caseload of COVID. And then we move. Are we showing the results now for these already? Okay, so can I just put those back up for me for a second? I'm still getting used to it as well. So overall COVID preparedness looks pretty positive, sitting at around from the 5 to the 7 range for the remote, and then a few not feeling too good. So what we obviously are looking at as an organisation, trying to move that to the right. Next one. Some cases looking pretty good again, and we'd expect that this will move to the left as we go to the next one. And the next. And clearly we're into the trouble being that that could be a pretty short period of time between those 3 slides. And then the next one. So at this stage, we're sort of wanting to chart this over time. I'm very conscious of the psychological safety, the stress levels of people, and obviously at this stage of low community spread. We wouldn't want to be seeing that look particularly bad right now, but we'll do that again in time. So we'll move on to the next one, which is got a range of questions around the support that you feel that you've had from various organisations and entities. So this is generally taking your view on how you feel about the response to, and again in response to your workplace. What's the response to COVID and the support for you so far from WA Health? Have you already gone to the last one? Okay, so everyone's answered the poll 2 already. Can I see the results of that? Thanks for the patience with the technology. We seem to be going forward rather than backward, which is the traditional thing that used to happen with slide carousels in this theatre that were up the back there with those blue and white slides. If some of you might be old enough to remember those. Back in the day. Still going forward at this point. We are unable to go back. It's all right if we can't go back. No, before that. Okay, so have we done this one already or not? We skipped it, didn't we? Okay, so if you wouldn't mind writing this question now, is that coming up on your phone? Thank you. I know that my cognitive decline is imminent. Dr. Borshoff's pointed that out to me in his recent learned article in Australian anaesthesia over a few weeks before I will be having soggy wheat bix in the morning, lunch and dinner. But I didn't think we'd seen this question. And, you know, from my perspective, obviously this is, we're not doing research here. This is really just to get a sense of how we're all feeling, gives people a chance to talk without talking all at the same time. And, you know, we've had our conversations with WA Health that have been pretty tense around certain things, but overall the relationship's been magnificent. And the professionalism of Andy Robinson and his team's been extraordinary in dealing with what is an unprecedented issue. I suppose there's then the objective question around the gap between intention and delivery. And my concern has always been, in a situation that's being managed by government, by politicians, is that the gap between what a government wants to do and promises to do and what it actually does, they normally fill with spin and to try and put a positive light on what's actually happened in order to keep their own job, that's just the nature of politics. There's nothing evil about that. That's the way the system's built. But in a situation like this, we've been very quick to call out anything that starts to look like spin because it's just too dangerous. So, for example, this week when, you know, very well-meaning, one of the chief medical officers of the Commonwealth goes, now the COVID Safe app is doing exactly what we'd planned for it to do. It's been working as we planned. You know, now that we're getting some contacts out of Melbourne, and we had to call them out and say, well, no, the COVID Safe app has been a disappointment. I think everyone was over-promised on that app, and everyone knew that government's over-promising on a tech project was going to be a problem. So that was an example of having to call them out on spin and say, no, let's just stick to the honest science here. So WA Health, yep, thanks. The next one. Employers getting good support there, but a bit spread out. Okay, and the next one. Direct manager is such an important one because this is the one that is most often comes through as being the most important thing in someone's particularly psychological safety at work. Because often direct managers will either make up for or destroy the operational situation of an entire workplace. And certainly in all the FIFO research that they've done lots and lots, and spent lots of money on it, it's often about the direct manager. And so they put a lot of money into training those people, and I think we need to put more attention there. And next one, please. And federal government not being rated as highly there. Obviously, the people at number 8 are the ones on JobKeeper. Okay, let's go to the next one, thanks. Thank you for that. And the next one. We do want to be brutally honest about the value of the membership of the AMA, and we do, you know, we're AMA members. We want to get something out of this combined asset that we have, and that's part of our being honest about ourselves and being mindful about what the AMA is reinventing that whole process now, and that's what Bennie and his team are doing right now. Okay, next one, thanks. And so this question's already been live, so I think this is an important one, is that people are not necessarily confident, and it's a pretty good spread of people saying that they're not necessarily confident that they will have what they need to do the job safely. And the next one. Okay, so this is about risk controls, and this relates to your safety at work. So this is workplace health and safety. And I want to make that distinction between that and what we do medically for the community. So let's put this one on, please. Next. So what we're looking at is the hierarchy of controls that are available is around elimination, substitution, engineering, administration, and PPE. I just wanted to get a sense of how you feel around the ability to control the amount of disease coming into your workplace. I suppose Clive Palmer's trying to do his best to reduce one of our better elimination strategies in Western Australia. I don't think it'll be successful actually in the High Court. In the Federal Court even, I don't think it'll be successful. And just show me how the next one's evolving, please. Okay, so this one is please rate substitution. So telehealth's the best example here, and obviously we've got an ongoing discussion now with the government about telehealth. So it's interesting your frame of reference. The federal health ministers very much touting the fact that they managed to get done in 10 days their telehealth plan. They said we'd already planned this. You know, we were going to do all of this. It's just that we had a 10-year plan, and he puts that out like it's a good thing. That they had planned to take a decade to do what we all have seen, that they actually, you can get this done in 10 days if you're not on Canberra speed. And so it was an incredible sort of accidental, I suppose, promotion and admission of the fact that normally around here it would take us 10 years to do something. You can get done in 10 days if you get on with it. So telehealth substitution and unintended consequences. You know, we had some attempts, some very, I hesitate to call them entrepreneurial, but we had some very voracious attempts to use those item numbers, and then had the concern about people not being connected to a practice, and then we got the opposite concern, which is that they might take it all away. And so that's where our advocacy is at the moment, and that's one of the top order issues for OMA. So next one. Engineering, yep, just skip through these and we'll collate these and get them back to you later. Next one. Administration, all the policies around the way the place is run, and that's not getting a great score. And that's to be expected because I think essentially most of the places that I'm aware of are running, they've got a bit of a COVID plan, but otherwise we're not going to be redesigning the way we do things necessarily. Next one. PPE, again, quite a few on the down at the bottom levels there, and that's something we'll talk about in more detail in a second. And next one. Are we back to the slides now? Thank you. So I'll whip through these because I want to ask you some more questions. Yeah, okay. That's out of the order that I have here, so I don't want to do that slide. Can you take me to the poll 4? We've done poll 5. It's about workplace health and safety. It's the next question after that, isn't it? So, and on to the next, and this is just about the administration of the health and safety, so that question's live now. And the things we're asking here is to have a visible and strong presence. Have you received adequate training at this point around your own workplace health and safety as opposed to all the other administrative principles? Is there adequate workforce where you are, and do you think that will be there if we get more cases? And what's going to happen if there's an escalation plan for COVID waves, and your confidence in your organisation to deal with it? Thank you. Okay. If we can keep that question open and can we put the slide up, which is the matrix? PPE matrix. So I want to bring you up to date with where we're at on PPE specifically, because I know that's a great concern for pretty much everyone who's going to be in contact with patients, it's the last line of control. It's the least effective method of control because just as a bulletproof vest is for a policeman, really if it comes down to you relying on that for your life, then a whole lot of other things have gone wrong before you get up to that point. But there are some people who have to get up close and personal with these patients as a result of our work. This is the best standard available in the country at the moment. This is the Victorian Department of Health model that was brought in on the 31st of July. And the differences to what the national standard are, they've gone out ahead of the national standard and made it stronger in relation to healthcare worker infections, unfortunately. In that state, over 1,000 now, which is, depending on who wants to put a spin on the numbers, somewhere from double to 6 or 7 times the infection rate in the rest of the community. So whatever else you want to theorise about, however clever you are on infection control, that number can't be denied that there's something going wrong. So they do what they used to do in the mining industry and blame the miners. So they used to say there's a mining collapse and 10 miners were killed because they didn't dig the hole properly. But along came modern workplace health and safety where the responsibility for deaths was put on the managers, and all of a sudden the deaths went away because the penalties were there for the managers, and they introduced safe systems and would not let the workers put themselves in danger. And so that is the difference between an epidemiological response where, as you know, they're balancing all the time between the risks and the benefits of certain actions that they take and accepting that there will be some infection in the community. And what they've done is they've gone and applied that model to the workplace, which is inappropriate because in the workplace we don't accept that you can get infection at work where there is a reasonable risk control that can be brought in to control it, like radiation from X-ray machines. We don't accept that just occasionally someone has to get cancer who works there because the benefits of X-ray are enormous. And it would be very expensive and difficult to wear a lead gown all day, so obviously that's ridiculous. So they're applying the epidemiological model to workplace health and safety, which is inappropriate, and we've got to drag them back using whatever method we can to do it properly. So where they have upgraded it in Victoria is particularly around providing airborne protection for settings with, so aerosol generating procedure, that we have that here, but also in settings with high numbers of suspected or confirmed COVID positive patients. And there's some question around what high numbers means in that context. And but our argument is that means a similar situation to community spread in Victoria at the moment. And the next one is uncontrolled settings where persons with suspected or confirmed COVID are treated, where there is a need for frequent PPE change or is a risk of unplanned aerosol generating procedures or generating behaviours. So you can see this is a much more sensible standard than that in WA, which at the moment doesn't take account of all those things. It just says only if you're doing an aerosol generating procedure on a COVID positive patient. So standard care of COVID patients in Victoria now, you get a respirator in addition to all of the other things, unless it is only limited contact for a short duration in a controlled environment with a predictable patient. So, those I think are the pretty small minority of the times you'll be dealing with a COVID or a suspected COVID case. So next slide, please. And these are really going into the more detail around some examples of those circumstances where you would definitely get a respirator, as in that bottom sort of highlighted box there. So healthcare workers in dedicated COVID-19 wards, even if they're only suspected patients, emergency departments, urgent care centres, or anywhere where suspected or confirmed patients are being treated. And in an area of high community spread, you would expect that would be pretty much everywhere. Open ICUs, within a pod, aged care services if there's anyone who's suspected or positive, and anyone giving prolonged disability support. So the problem is that we have an uphill battle to get this introduced nationally. And the AHPPC today have approved a new set of guidelines in response to this, in response to the Victorians going out ahead of them. They're publishing it on their website tonight. I haven't seen it yet. They're possibly still arguing over it, but there's a strong pushback from the infection control experts group, who are infectious disease academics and infection control experts who are highly respected in those areas, but they're not frontline people on that committee, although they say that they talk to frontline people. And very much adhering to the idea that this is not an airborne illness, so you rarely need a respirator. So that's the political argument we're having at the moment. I think until we can get predictability around the situation, and while we're targeting zero healthcare worker infections, we should try and push that so that we get at least what the Victorians have and then move on from there. And I'd like to just go to the next poll, which is three different questions, I think, here. So if we did have that Victorian standard, if you could just check off the things that you also think we should have in addition to that for those people who are going to be working around COVID. Fit testing of the N95 is required in the AS 17152009 standard, which is a standard that governs respirator masks, but it's not being applied in most locations except for South Australia, which has good wine and some churches and fit testing of N95s. To be added to the list of appealing things in South Australia. And then if we can go on to the next question. I might have been a bit quick on that one, but it was fairly clear. These are our options in terms of what do you think we should do in order to get better improvements around progress and workplace health and safety. So this is the AMA looking for your guidance on how strongly the profession feels about these issues. At times I get passionate about things that no one else is interested in, so we want to be sure that if we're going to encourage campaigning on these issues, then we need to understand where to go. The WorkSafe thing I will mention, in Victoria they also have urgently introduced legislation that all infected employees, as defined by whether they were in the infectious period and subsequently shown to be positive, if they have attended work, that is a reportable, mandatory report to WorkSafe in Victoria. So they are de facto, they have created a healthcare worker infection registry, because it's mandatory for it to be reported if you attended at work during the asymptomatic or pre-symptomatic phase of the COVID illness. Whether or not it spread, you got it there, whether or not it spreads, whether or not you get any bad outcome from it, you have to report that to WorkSafe in Victoria. So what we've been pushing for, some of us have been asking for since January, is a national register of healthcare worker infections so that we can better understand this, and that's one of our advocacy positions. And if we can go on from that to the last question, just to get a sense of your own personal situation, pretty simple one. And a general question is, are you confident you'll be able to access the PPE you need? Because it's one thing to have it. I've been reassured this week by the Director General we've got plenty of PPE in Western Australia, but I don't know that necessarily that's going to flow through to the people who need it when they need it. So thank you for voting on all of those questions. I will throw open some questions at this point. If you can let me know, Sean, if there's any coming through online, and I would welcome any questions from the floor, or observations or criticisms of me personally, or the material that's been presented. I guess we want to get the sense from you if we're heading in the right direction. The new federal president, as most of you may know, is Omar Khurshid, who's my predecessor here in WA, has hit the ground running on this and many conversations with the CMO today, with several of the CMOs today about this. And our default position at the moment is, why would we accept less than Victoria, and why wouldn't we want more than that if it's gold standard? Karina Power.
Yes, I'm
occupational
supportive of
and
guidelines being written to the cautionary principle, and then if there's any deficit in stocks of PPE or logistics, that's made transparent and is shared as appropriate to need. My question is, do we actually have a feel for the N95 masks in the state? What are actually Australian standard and will be effective if you are exposed to COVID?
The feel is difficult to have because not many people have been fit tested, and of course we do know that the standard N95s that we have generally tend to fit Caucasian middle-aged men, funnily enough. Yet another thing I can add to my list of things to be grateful for. So there's a problem without fit testing. We don't know whether they're N95 or not, and if the mask doesn't fit, it's not N95, it's basically the same as wearing a surgical mask because of the entrainment. Correct? Yeah. We don't know the answer to that. I know I've been given reassurances just this week by David Russell-Weiss, the Director General. He says the term he keeps saying is there will be plenty of PPE, and he wanted me to get that message out here tonight. He is a member of the AMA, but decided out of respect as we're discussing the EBA tonight and potentially criticising his department that he wouldn't come so that we could have an open conversation that would be reported back to him instead of him watching it directly. Shout out to you, Russ. But I think that there's strong reassurance. We've supplied Detmold manufacturing D95 masks in Australia, which are being well reviewed, but access to them here, we've got no guarantees around anything at the moment, nor the quality. No one's shown us the goods. Any questions from online at this stage? Okay, so PAPR is powered air purifying respirators, which are those sort of things you see that seem to be standard overseas when you see people treating COVID patients in ICUs and operating theatres around the world. And in fact, they're sometimes called the full Wuhan. The PAPR is, it has its drawbacks, but it is very good filtration, and if people are trained properly in its use, it's much more comfortable to wear for prolonged periods of time with difficult procedures. I know we have small suppliers which have been accessed by some ENT surgeons, for example, because they get everything they want, as they should, because they've got to operate in timely spaces, which are infectious. But I think that my principle would be that things like the Halo PAPR, which is available in Australia, we should have been ramping up manufacture of that months ago, and we should be looking at all sorts of alternative devices and being a lot more creative about it. My personal view is that if someone can access protective equipment in excess of that available in their workplace and you don't let them use it, then I think that there are all sorts of problems to that we're going to be exploring with lawyers. But PAPR certainly has a place, I think, for people doing prolonged care, and I think that Canada's a pretty good standard. Their standard for initiating invasive ventilation is an N100 mask and full Vertex suit, hooded everything, and we're just not looking at that because people are telling us it's not necessary 5-6 months into understanding this disease, which is not following the precautionary principles. Hi.
Hi, Andrew. I'm Roger Lai. I'm an occupational physician. I agree with your comment that we need to take a work health and safety mindset into this. But my impression is they're not in the loop within the Department of Health. It really is very much run by infectious disease, public health, emergency. The work health safety isn't in the loop. And I was just wondering how the AMA could assist to bring them to the table or bring them into the loop there.
Yes, well, can I tell you that it's no fault of the occupational environmental medicine specialists that they're not in the loop. I know there's one in particular who's been offering to help since the get-go, and in Victoria they certainly are in the loop, and maybe the explanation as to why some better protections have been promoted by the CHO there, even before they had their outbreak there. We will do our best to introduce that. There's been direct conversations with the CHO, who has politely smiled, as he always does, and I don't underestimate his professionalism. But the thing is, it's easy to hold your position about how you're doing things when your case numbers are close to zero. But what we have to anticipate is a Victorian situation unfolding here. We've got to stress test our system now, because they've been totally caught on the hop, and they're being helped out by every other state. And that's not going to happen for us if we're fourth or fifth in a row when we get the inevitable outbreak. Fortunately, when Victorian truck drivers come unquarantined to Western Australia at the moment, there's no big events on that might attract a Victorian, such as a football match. Why would they want to go to see Collingwood play? You can see the anxiety that's coming through in my sarcasm, but I think you're absolutely right. We will try to get more diversity in every respect. General practice, aged care. Aged care is the risk. That's so brittle, and it just, when it breaks, it's the dam that breaks and it flows into your public hospital, because you can't leave these people sitting around in this facility with no staff. Once it's in your public hospital, then you've got staff furloughed, you're getting staff infected, and then the things start to roll along from there. And those workers in aged care, in my view, are the equivalent to the migrant workers in Singapore. They're a bit invisible to the rest of the society and the system. They often hold several jobs and they're moving between different places, and they can't afford to not work. So the incentive to keep working despite symptoms, even though this combination of carriage disease is strong. Do we have to wrap it up there, Benny, in order to let you have a chat about your things? Was there one more question I can do quickly from the online? Yes. Thanks for that. Thanks for your attention to COVID part. I'll come back at the end, and if there's some overflow questions, I'm more than happy to stick around for a bit longer. But I'll introduce Bennie back.
Thanks, Andrew. The next section is on the EBA, and I just want to reassure everyone that the AMA-WA is absolutely committed to securing a better agreement for you as public hospital doctors from the government. It has been a long and arduous journey since 2019, with lots of discussion behind the scenes. So tonight, what I'd like to share with you is some of the works and process and frustrations that we as an organisation have been experiencing, but more importantly, is to get your guidance on what the next steps are. But before I move any further, I just want to acknowledge all the works that's been done, not just by my team, but also from the Public Hospital Doctors Committee, chaired by David McCoubrey, our Vice President, and also Megge Beacroft, who will talk about the doctors in training issues a little bit later. So just a little bit of background. The current agreement that we've been having started in 2016, and we knew what the issues of the agreements are, because you have been telling us what they are, how it's been actually used, interpreted and treated by your hospital management and also health service providers. What we're trying to do in this negotiation is actually let them know what you are facing as a hospital doctor every single day, and get them to acknowledge what these challenges are. On the other side of a negotiation table is the Labor-McGowan government that was elected 3 years ago, on a platform that they have stricter parameters on public sector wages. So we knew the negotiation would be tough, and this is especially tough when they are extremely popular at the moment. They've set a limit of a $1,000 pay rise per annum across all government services. But it's always been our intention to actually seek just better compliance to what we've got, improve working environments and better conditions to improve the morale, the culture and the safety of the workplace, which are all the principles that we actually believe the Labor Party took to the election in 2017 about how they want to value the entire workforce. So next slide. Yep, thank you. So just want to paint a bit of a picture of how complex for us it is to navigate the negotiation. It is our job, and the team that's leading the negotiation for the government is the Director General of the Health Department, Dr. David Russell-Weiss, that Andrew's mentioned before. The responsible ministers include, right from the very top, the Premier Mark McGowan, the Health Minister, Deputy Premier Roger Cook, but the lead of this negotiation, in fact, and the responsible minister is the Industrial Relations Minister, Bill Johnston, who also oversee the Public Sector Labour Relations Division. So what's different is that in previous agreement we deal with pure health people, but in this time we're actually dealing with an Industrial Relations Minister that just deal with bodies like AMA. We bargain in good faith, and there's been a lot of to and fro, and we've been interrupted intermittently by something called a voluntary assisted dying legislation that's been introduced, as well as the beginning of the COVID-19 pandemic. But over the last 3 months, things have escalated. What we're worried about is that the government is not listening. They simply are not doing that because we know that every time when we appear to be making inroads, we were actually presented something back that actually looked like something that's just been repackaged from the first offer. They are things that you face every day at the hospital that we don't take it lightly, but they seem to not understand. Our assessment is that the government is betting on the fact that, on the goodwill that you're, of your commitment to your job and to your patients. They're relying on that goodwill. They're counting on you to keep the system going and producing top work and patient care, not because of a health system that's supporting you, but despite of it. So now I'm at a point where we want to actually get your feedback and just harness your sentiment as a profession so that it will shape what we bring back to the government next. So how do we do it? The starting point 18 months ago was that there were a list of 86 issues, or what we call claims, that we've collected because you shared it with us. We have the evidence that we can provide to the WA Health Department, and we're trying to resolve them to the doctor satisfaction, but also better for the patients and also the health system. From an agreement perspective and negotiation point of view, bringing 86 is just a bit too much, but so we can actually group them into 5 categories. And these are listed here behind me on the screen. These are not just feedback from you. In fact, when we actually match them together, they're very consistent with what has been identified in reviews on health service providers into, for example, North Metro. And the surveys that we've actually conducted last year and also recently, which I'll show you a little bit of the results. We know that because you're telling us that there's detrimental effects on the medical workforce morale, the culture of the hospital, which you lead, and also the training environment, but more importantly is the patient care that gets impacted. So briefly, I'm just going to go through the 5 points here before I kind of do a deep dive on a couple, but the first one is the permanency for senior doctors. Senior doctors are appointed on contracts for no longer than 5 years, and there's no automatic right to renewal. Your employer only has to provide you with a letter of notice within 12 months of a contract expiring, informing you that your contract won't be renewed without any justification. The second point is about portability and retention, and that Meg will expand a lot more, but these are very much affecting the doctors in training. and we've all been there before. If not, a lot of DITs are joining us online that we know tonight. The employment situation of doctors in training are pretty unique. They have to move from one hospital to another, one health service to another. And I think there are major issues in the agreement that doesn't address the movement of the doctors. The specialist recognitions here is interesting because we think that WA Health continue to place and appoint specialist practitioners in non-specialist roles. So there are plenty of non-specialist roles out there that attract lower salaries. So we're keen to actually fix it. And they're particularly affecting the rural areas and specialist general practitioners. The fourth one is about revised on-call and recall provisions for both the doctors in training and the senior doctors. There are a lot of practices that are not being obeyed by the health service providers, and we are extremely worried. And lastly, this is about, in your agreement, there's an option of arrangement A salary, and AMA believes that that should be recognised as a base for all purposes for the agreement moving forward. So we started with 5 broad areas, and the first one that I just want to do a bit of deep dive before I throw to Meg is, if you please move the next thing. Yeah, okay. So just want to turn your attention to the first item, which is permanency. And there will be a couple of Slido questions at the end of this. WA doctors are the only non-executive public sector employees without permanency. Currently, the WA Health offers retains arbitrary non-renewal of a fixed 5-year contract with 12 months notice. Every other state in Australia offers permanent employment to public hospital doctors. I don't know what I need to say anymore. We even know that even on the 5-year contract, there are in fact many doctors who are on much shorter contract, 6 months repeated contract, which we think that there's a blatant disregard to the current agreement. Now, at the last election, the Labor Party was elected on a platform to recognise the importance of permanency and providing employment stability and security within the public service. So we're just trying to understand why the doctors are so different, if there is some fairness about that across the board. The Premier specifically actually sought to fix this problem. They have been converting other health service workers from casual and fixed-term contract to permanent. The only exceptions were the executive officers, and you guessed it, it's us doctors that are not in that group. So this is a health system that you bear the ultimate responsibility for patient care. You need to make the decisions based on the outcome for the patient without fear or favour. And the government and WA Health is using this as a means to control over the employees. That's what we think. And certainly what you see in the slide behind me is the survey that we've conducted in the last 2 to 3 months. We've had over 900 responses. Thank you for all of you who've actually filled in the survey, which shows 87% of you are not comfortable to raise concerns for fear of retribution. Despite 72% of you telling us that fixed-term contracts have a negative impact on morale. So we think that as an organisation, permanency will not only boost morale and culture, but it will improve quality and safety, and ultimately it will actually provide savings. There is a link between quality and safety, and in fact savings to the system. And we also believe that it will instill a degree of fairness in the system that you practice, and rebalance the relationship between WA Health and the doctors. And it will obviously provide the same employment security that every other public sector employee is entitled to. So, I want to actually get some feedback from you tonight in determining the next steps. What will differ from the previous Slido question is that I will not show you the results because the public nature of this forum, and we want to actually formulate a good strategy in our negotiation and not be used against us. So can I go to the first question, please? So if you can actually bring out your phone, that would be great. Going back to Slido for all of you online as well. So the first question is, are you prepared to fight and hold out for permanency? What this means is that if we don't get it, we don't have an agreement. So I'm just looking at the clicks on the top right and go, let's get a few more through. All right, the next question, please. All right. If we have to do something, we would like you to be behind us. So what we'd like to know is what kind of measures you are prepared to do to secure permanency. You can tick more than one box here, is that right? Yes, thank you. So please tick the there are 5 options listed, and I won't go through them, you can read. So really appreciate you kind of giving us some guidance of how we can actually get a better outcome. Yes. So so while you're doing this, you know, one of the issues that we face is that obviously WA Health can performance manage any doctors at any time, and there seems to be a lot of issues in regard to that, and we, as part of a negotiation, we just want a professional and fair system so that you know, we don't actually get treated by people who actually don't understand what roles that you play within the health system. Okay, so last question before I throw to Meg. So last year, senior doctors did not claim $47 million for hours worked. Are you prepared to take measures to stop WA Health benefiting from this goodwill? This seems to go up much faster compared to other questions. I wonder why. So on that note, I'd just like to introduce Megge Beacroft, who is the chair of our Doctors in Training Committee, to talk about the next entitlement.
Hello, everyone. For those of you who don't know me, my name's Meg, and I'm a surgical registrar and the chair of the Doctors in Training Committee because I have so much spare time. I'm here to explain the DIT component of the enterprise bargaining agreement because it's a bit of a complicated definition and does need some background. Currently, doctors in training in Western Australia are employed by a very complex system. I'm employed by Fiona Stanley, I'm paid by Charlie's, and I physically work in Joondalup. This complicated system of boards and public-private partnerships has created an environment where doctors in training are on a series of 6 to 12-month contracts, spending many years moving around the system, not because we don't like stability or hate having paid maternity leave, but because doctors in training can't train to be specialists in any one hospital. Ophthalmology's over there, trauma's over there, you only get your diluted peds for GP if you go to this hospital and your obs and gynae at another. To become the kind of specialist that we all aspire to be, that in fact many of you have led us to believe we can be, you have to move around WA and you have to move in and out of WA in order to pick up those essential skills. Doctors in training can work every day, nights, weekends, Christmas, holidays, serving the people of Western Australia for many continuous years, on average for a decade before they gain their specialist qualifications. And they do this on a series of contracts where if you get pregnant at the wrong point in your contract, you're eligible for nothing. If you decide to take an overseas fellowship so that you can be the first person in Western Australia to perform an endoscopic gastric sleeve, you're not the person that's going to be attracted back to work in Western Australia. It goes beyond just paying back the service of the people that work, well, I wouldn't say the hardest, but pretty hard for the population of WA. It's also about building the kind of specialist medical workforce that we need for the future. WA Health have said that they're committed to building this kind of a specialist medical workforce, but I can't undertake a fellowship overseas because if I do, I have to write a letter to my employee and essentially beg them to put me on unpaid leave. Otherwise, I lose everything. All of those years of continuous service, all of those entitlements. It's particularly felt by women because if you're on a series of 6-month contracts, I don't know about if there's any gynecologists and obstetricians in the audience, but pregnancies are a little bit longer than that. So you get pregnant and want to take maternity leave on a 6-month contract, and you'll be out of contract by the time that comes around. And there's been many trainees in various specialist colleges across Western Australia who found themselves out of contract or suddenly moved to a private hospital where they can't access their WA health entitlements despite the fact that they're doing public work for a private employer. So we feel that this is a very important thing in an environment where we know during this negotiation we can't ask the government for money they don't have. We're just asking for a fair go. I just want to speak a little bit to the permanency as well and know that permanency is not something that we can get. Doctors in training are more after training length contracts rather than 6-month contracts. But permanency is important for us too. If we're going to achieve a diverse workforce that stands up against things like bullying and sexual harassment, then we need consultants that are willing to stand up against these things, that are willing to raise their voice in defense of these kind of culturally and safe workplaces. And many of the younger consultants who are afraid for their jobs in reality, we can't build a culture and build a health system for the future if everybody's afraid of making their mortgage payments. People are afraid of building quality improvement. People are afraid of speaking up against medical administration because they know that their next contract won't be renewed. I think we can't build a health system where there's no job security for the people who would be the change makers. Very happy to answer any questions about this, but we also have some questions for you guys, if you don't mind, just about the next phase of our negotiation. I'm not going to spell them out. I'm going to let you guys work through them. And then if anybody has any questions for us, and I'd like to ask Andrew and Bennie back to the podium if you have any questions for them, please let us know. And the membership organisation is only as powerful as the voice that comes behind us. So let us know what we can do for you, and please give us the questions.
How many junior doctor FTE are we short in our system at the moment?
Well, that depends if the Department of Foreign Affairs let in the English-Irish invasion for the year, because it's currently under negotiation. But I think we're just under 60 FTE short at Fiona Stanley, and about just a little bit less than that at the other tertiary hospitals. I know that there's emergency departments that are critically understaffed, talking about dozens of shifts a week going uncovered. I think that these are critical workforce shortages we're talking about.
And that's been as a result, presumably, of the borders situation for the most part.
It's a complicated.
Yeah.
I think it's more complicated than that. I think our reliance on the English-Irish workforce is a symptom of a medical workforce planning and recruitment strategy problem, whereby people are unable to fulfill contracts and also attain careers or skills under the current workforce system. I think in some ways it's about our dependence on overseas doctors, but why are we dependent is the more important question.
And it gets even more complex when you have the Irish, for example, are getting strong carrot and stick measures to stay in their own system at the moment as well, so we may not be able to attract people in the same volume as we have previously. It might be just those who can't actually get a job in Ireland rather than the other way around. Keep moving on, please, so these questions once you get a reasonable number. So presumably then getting leave, difficult?
Non-existent. There's none available in some hospitals until next February.
So that's on top of
and that's before we have COVID.
Problem.
So that's before we have
yes,
people out of the workforce, self-quarantining. You can't get leave now anyway. I mean, we're campaigning for access to our leave, but
yeah,
there is none, is the reality.
And so this is what I mean when I talk about the system being brittle, because in aged care, the reason why it failed in the end was that no one turned up to work in Victoria. So that's what forced them to step in, was that the aged care providers were having to ring the state health department and say, we've got no workers, we've got 60 residents, there's no one here to look after them. And some pretty, very distressing things ensued. So keep going if we can through these. And what about the impact on training?
Of COVID or of?
Well, of the whole current situation, and what can we do about it? I mean, because exams are disrupted?
Yep, exams are cancelled for most specialties.
Yes.
I think it remains to be seen if any colleges are going to successfully have exit exams, those that are dependent on exit exams this year. But if there's already a huge bottleneck for specialist training positions, and the reality is Western Australia doesn't need more interns, we need more specialists. And if we can't get people through the specialist training pipeline, we're not going to have the specialists that the community needs. COVID's going to make that bottleneck worse, because nobody getting out for exams means nobody getting in. And that means we're another year behind our targets for achieving adequate supply of general practitioners, surgeons, vascular surgeons. I don't know how many addiction specialists we have at the moment, but it's less than 10. We won't be able to achieve those goals for an extra year. So even when we were unable to train the specialists that we needed to train, we have interns and specialists, we didn't have a whole year's worth of disruption.
Yes. And some of that's unavoidable, but what we'll be seeking is sensible solutions to these things to get out of it in a non-bureaucratic way. And what we have blundered upon is an incredibly paternalistic command and control emergency response. And it's necessary to have command and control, but that command and control has to make sense to interact with our culture, which has become collaborative and it's become teamwork. And we're used to now, the whole way we train from student level up now is you could be the one in the room with the solution. The most junior person could well be the smartest one there. And now we're reverting to 1975 and being told to sit down, shut up and do as we're told. And we cannot have that infect the way that we recover from and move forward from this situation. So we're moving through those questions there. While we do, are there any other questions from the online or from here about the EBA style issues? We'll get a microphone down the middle and one over there. Thank you. Is there one from online I can answer while
we have sent, so the AMA has demanded essentially an answer from the DG, and we have a meeting next week or the week after?
next week. With
the Chief Medical Officer, in order to address the kind of critical point we're at now, because if we don't do something right now, the second we are already a scary percentage behind our target medical workforce in Western Australia. And the second we start isolating even by 5%, we may struggle to even deliver some critical services. So we've got a whole list of suggestions, and having been involved in this process for a while, I won't go into all of them, but there's lots of things that can be done now that are being negotiated, but whether or not what comes out of that remains to be seen. The planning hopefully will work out.
Okay. There's a question in there. Yes. Yeah. Yeah. Yep. Your microphone's on now. So
Sorry, I hope people could
you
hear
could just
me.
start at the beginning of what...
My
Yes.
point is that every facet of medicine seems to be in crisis,
Yep.
and not to forget general practice, because
By no
we
means.
are
I think
there as well.
Thank you. And it's a point well made, and it's why we've included general practice specifically, and want to hone in on the. There was a hand up over here somewhere. Hone in on the provision of PPE. PHNs, the primary health networks, are supposed to be supplying PPE. They've never been a supplier of anything to anyone in the way of equipment before. So all of a sudden they're going, well, how do you hire a van? And done I think a very good job at very short notice after being asked to do something they never had to do before. Well, where was the pandemic plan? The pandemic plan overseen by the federal minister, who was one of the first people in the country to get COVID, which perhaps was a metaphor for our pandemic plan. Do we have another online question before I go to the lady in the audience? Okay, over here, please.
Hello.
Hi.
My name is Stella Fabricant. I'm a psychiatrist at Fiona Stanley Hospital, and I would like to express my total support for our colleague doctors in training. I've been one of the doctors that I think has spoken up, expressed my opinion about the hours of unpaid work, difficulty taking leave, and I have received the appropriate non-renewal of 5-year contract. So one thing I've noticed as I've gone through the EDA, probably for the first time, having to look at something like that, because I'm not normally that way focused, is that we have very generous provisions for professional development for both specialists, to a lesser degree still, some provisions for our doctors in training. But because of the shortages that we have I feel bad about speaking up about it because it seems petty compared to maternity leave and not being able to take annual leave.
Well, we can't get married.
We can't take our professional leave entitlements and train and keep up our skills. We end up doing that in our own time, working harder on top of the extra hours we put in.
Yep.
And yet there's
Thank you. I'm going to have to wrap things up in a second. But did you have a particular question? I think your point's very well made.
Is there any way of actually, is there a way of monitoring whether the professional development leave that doctors are entitled to is actually being taken by trainees and specialists?
Well, I think Bennie mentioned the difficulty with getting compliance with the EBA from the health services is ongoing. To be frank, look, I'll go a little bit off piste here and be frank. I think we've had many surveys which have shown that there's bad culture, there's poor engagement, there are people who feel bullied by the process. We believe that the non-renewal of 5-year contracts on a discretionary basis is used as a performance management tool rather than simply as a convenience for the planning of the health service. I think that there are people who have been punished arbitrarily because they're disliked or because they speak out and try and agitate for change. This bullying culture, I think, has gone on for too long. And there may not, may not be individuals, but you can get bullied by a system as well, although I think there probably are some bullies within the system as well. I think it's been a failure of leadership. Perhaps there's been a problem when the responsibility shifted from all being under the Director General to going out to boards and back again. I put the responsibility firmly back on the Director General to fix the culture of the department of which he is the Director General. There's a reason for the title, there's a reason for the pay package. You have to take responsibility for the results that are coming through in the end. They know that they don't comply with the EBA on occasions when they should. They know that the juniors have for a long time been feeding back excellent data, world standard data about the situation.
Hospital Health Check opens Friday.
Hospital Health Check. And so I'm fed up with it personally. And the time for excuses and for friendly chats about things and just rolling on is gone. And we need to get some power back to the clinicians, for the heads of department, to be able to have some say in how their department runs within the hospital without then being told we no longer need you a little bit later. We have plenty of examples. We're prepared to ramp this up and take it forward, but we need to take the membership with us. I'm sorry if we didn't get time to get to your question. We're happy to take them in person, but we are conscious and want to respect people's time as well in getting away. If you wanted to come up and ask something afterwards, I think that you will agree that the AMA-WA Council has made a superb choice in appointing Dr. Beacroft to our board recently through her presentation this evening. It's good to see the future of the profession stepping up into these kind of advocacy roles. Thank you for coming out this evening. I think you'll agree we've made an excellent selection for our new CEO as well. And congratulations to Dr. Omar Khorshid on being elected federal president. He can't be here in person tonight, but it's with a degree of confidence that I say that I think that with that presence in Canberra now, things will be easier in terms of having our message get across. So thank you all for your time this evening. Send us more questions, stay in touch with us, whether you're online or here in person. We really appreciate that you're the reason we're here. You're the reason we have this terrific asset of the AMA, and we want to turn it into something very useful for each and every one of you. Thank you.